Hello and welcome to this month's live social media event with the Sugar Queens. I'm Dr. Eden Miller. I'm a board certified family practitioner. I'm in Bend, Oregon. I'm also a diabetologist and obesity medicine specialist. And I'm so happy to see Jen back with us. Jen.
Thank you. Thank you. I'm thrilled to be back. I'm Jen Goldman. I'm a professor of pharmacy practice at Mass College of Pharmacy in Boston, and I direct and run the diabetes program at Well Life Medical in Peabody, Massachusetts.
And I'm Davida Kruger. I'm a certified nurse practitioner in Detroit, Michigan.
Well, welcome, ladies. We are doing CGM Connections. So everyone on, stay with us for the next 30 minutes. You don't want to miss out. We're also going to be sharing stories. So we want you to be active. This is our collective mind. We want to see some of those things that you've been experiencing out there. And most importantly, our recommendations of how to make the most of our interactions with our patients who may be a little less tech savvy, right? We all know them, right? We don't want to shy away from somebody who's not a tech master. And we also don't want to let age impact us. Okay. But before we share our stories, we want to hear from you, all of you who are watching and listening on our social media platforms. Come on, everyone. What kind of questions do you have about CGM? What is still lingering out there that you're dealing with, those pain points? Do you have any patients who don't want anything to do with technology, right? We all have it, right? And when you see that, what kind of challenges have you encountered with it? And what have you done to kind of overcome that? So please, as we are going through the next few minutes, we want you to put in that chat the questions, the conversation, and so we can address it. Okay, so let's dive into our discussion and have everyone think about this question on your screen. Who should initiate the discussions about CGM in clinical practice? Jen, thoughts?
Anyone?
Sure.
Everyone.
Davida.
And everyone.
But here's the thing, Eden. Everyone should do it. Every healthcare provider. Doesn't have to be an endocrinologist. It doesn't have to be primary care. I don't care if it's your obstetrician or your GYN or your dentist.
Well done. Well done.
Everyone should understand if you've got a patient sitting in front of you that has diabetes, you should be thinking about CGM.
Yeah.
And
it should be an automatic question. Do you have a sensor? From every healthcare professional.
Sure, right? It doesn't land in any particular person's lap. It's team diabetes, right? And in all being on team diabetes, we're all going to benefit from that. Let me just share a cute little story too, because it goes into that collective working together on the team. I just sat in a meeting at my local hospital between the CDCESs and the PharmDs. And they were going back and forth about, who does the CGM? And they're like, who's responsible? Now, me being all sassy, I walked in there and I said, you really want to know who's responsible? It's me. It's the person who's writing it. But that's a ridiculous statement. The reality is this: we're all responsible. And it went down to a story of an elderly individual who came into a CDCES and they had a low blood sugar. And at that time, the CDCES did an amazing job of engaging with the data, talking to the patient regarding it, making changes to prevent. And then they sent that communication on to the PharmD, who in my area happened to be facilitating this CGM. But here I was mediating between these two because the PharmD was like, no, it's mine. And I'm like, no, it's not. It's everyone, right?
Well,
everyone.
I think the other thing is there is so much advertising going on TV and elsewhere that now the patients are asking for it, and they should be, or their family members are calling and saying, hey, why does my dad not have a CGM? So I think, the conversations need to be everywhere. I know you guys know that I was recently in an airport and a woman was having a hypoglycemic event and I'm trying to find her sensor and I wanted to see the data and she wasn't wearing any. It wasn't wearing a sensor. And so, those are missed opportunities as a healthcare provider if you don't say, why are you not wearing a sensor? And this is what it is. But I think everybody should be engaged. And every line, even the MAs talk to patients about why are you not wearing a sensor, or not why are you not wearing a sensor, but are you aware of this technology?
Correct.
And how can we help you?
Well, it's also to remember top of line, and Jen talked to us a little bit about that. And we've been really talking about it's standard of care. It's 2025 ADA standard of care, which we could kind of flip around and say, if you're on insulin, if you're a type 1, if you're on any kind of insulin, you better be on one. So Jen, talk to us about a little bit about that.
Well, what I was just thinking is, yes, we all agree it's standard of care. We all do. And some of these providers do, and it's everybody's responsibility. Yet we just keep hearing about story after story of somebody not getting a sensor or asking for a sensor and being denied a sensor. Before we came live, you shared a story about someone with type 1 diabetes, a child potentially having to wait 6 months. And I shared a story. I have a friend with gestational diabetes, and their doctor wouldn't give them a sensor. So we have to continue to spread this education and information to all providers that it's really standard of care. What's the big deal? I don't understand how people can prescribe a finger stick so someone can check 5 points of time, but have a problem with a sensor.
Yeah, exactly. And you know what? One of the things too, as I've said before, and I even got a little spicy at the ADA last year, and I said, you may not be on board like us. You may not see the great value, which we figure give yourself time. But I would say this one thing: don't be a barrier. Don't get in the way.
Yeah. So I think. Well, I was just going to point out the change from 2024 to 2025 that I, was very, very excited with. So we always say anyone who has type 1 diabetes, even though we know people who have type 1 diabetes are not getting offered CGM, that should be a no-brainer. Anyone who has type 2 diabetes who's on insulin should be offered a CGM. But now the new standards of care saying is that diabetes devices, i.e. CGM, should be offered to people with diabetes. It should be offered to them. It should be recommended to them. And we have come so far because now we're saying that it's independent of insulin. We're not sure. We don't care if the patient's not on insulin. It should potentially be recommended. And I think the flip side that I don't want to forget to say is that, while maybe insurance companies are not there yet saying, oh yeah, the patient's not on insulin, so we're not going to pay for it. That may still be for a while, but I think the evidence is coming. And I think just what we know in clinical practice is coming. But I also want to make sure that you don't forget that sometimes patients get to decide how they spend their money. And if they don't have coverage, I have a lot of patients who will pay out of pocket for the opportunity to have all of that data at their fingertips, and family members will do it as well. And also, I can't say what someone else can afford, but the prices have become very reasonable, and there are places that you can get sensors that you can afford. So I just think that we need to remember that even if insurance says no, the standards of care do say yes for all people with diabetes now.
And if somebody's asking
Jen, how do you have that conversation with people, the caregivers, the persons, maybe somebody who's on board or reluctant? Share a little bit of how you do that.
If I just want to point out, if somebody's asking for it, that's an engaged patient.
Yes.
We should not be saying, no to them for sure. What was it you wanted me to comment on? I think I spoke over you.
Well, that's okay, because us queens interrupt each other all the time. So kind of give us this thought, because it just comes flowing out of our mouth like honey, right? But when you have a person that you're going, oh my gosh, they would do so great with CGM. Let's say a caregiver's there. Let's say there is a person that maybe you don't know for sure. How do you kind of bring it up? What are your pearls? What do you say when you talk about, hey, I want to talk to you about something? Like what are some of your thoughts when you do that?
So typically what I'm doing is asking, how do you feel? So it's important to gauge how this patient feels, and if they're interested in knowing what their blood sugars are. And when you have that conversation, oftentimes, people come with preconceived notions of things. They're going to make me finger stick and so forth. So if they're not familiar with the sensor, I might say, have you heard of a sensor? And then have that conversation if they haven't. And if they have, I have a friend, I have this. Well, what do you think about that? And let me tell you the difference. This is what you can get from finger sticks. This is what information we can get from sensor.
Right.
What do you think works best for you? What would you like? So, and that kind of leads into a little bit of that technology and how comfortable people are with certain technology or not.
Davida, other thoughts?
Well, I was just thinking that it doesn't take a lot to convince 99% of the people. And once they've worn a sensor and they can see what it's all about, they're not giving it up. Just to have that control over their life and their diabetes and to see, and people use the data in all 1,000 different ways. Not everybody's going to have their head hung in the, online looking at all of the charts and the graphs. And even as a healthcare provider, they use the data in a different way. But for the patient to know the direction they're going, where they've been, what's happening when they eat pie or, walk around the block, whatever it is, or, just take their medication. There's better, patients tend to take their medication on a regular basis when they can see what happens when they don't. So
Absolutely.
There's 1,000 reasons why I think patients who get it or have the opportunity, someone talks to them, they get to wear one, even if they don't, their friend's wearing one. I think the continuity for them and their care, I think it's huge. So I don't think it's a hard sell. The other thing is, I don't know anybody that really likes finger sticks. I haven't met too many people in my 42 years of practice that like finger sticks. And so I do think, I just have to say too, I just read this article. Now, mind you, it was in People. It wasn't in a scientific journal about, well, my niece sent it to me because she knows what I do for a living. It was a 5-year-old who was not wearing a sensor because the family had a dog that could detect glucose. Now, I agree that dogs do a nice job, but she was at the neighbors when she was having hypoglycemia. And supposedly the dog knew, but you would still have to figure out what was going on, get to the neighbors. I mean, there's so many different things where if the child had a sensor on, the person she was visiting could also say, let me see what's going on with your sensor.
Yeah.
So keep the dog, happy to have the dog, but put a sensor on that 5-year-old.
Multiple layers. And one of the things too, I want to remind our listeners is we've had a lot of episodes. So if you have a particular question or barrier or a thought or individual, go back to those episodes. We've had a lot of those that have really addressed some of those issues. So, Jen, I want you to share a story about this older gal who didn't speak English.
Yeah, so this was a lady, a lovely 87-year-old patient that I hadn't met before, and she was actually not on my schedule. She was on the schedule with we have a new nurse practitioner in my office who is amazing and wants to learn every single thing there is about diabetes and CGM, and so it's wonderful to have her participating. So she pulled myself and the students to be kind of involved with this patient. So this patient speaks Spanish, 87 years old, and is there with her daughter who's translating for her. So she's had really not checking her blood sugars, but her A1C, when I look in, coming forward, it's 7.9, then 8.4, then 8.8. So now this day it's 10. So she's not checking blood sugars. And so in this situation, my immediately thought, well, it's 10, she needs some basal insulin, what's happening. But we don't know what's happening because we don't have any data. And even if we had finger sticks. So when I kind of looked back, she had previously reported blood sugars, it was recorded, blood sugars are in the hundreds to 120s at home.
Always.
Yeah, right. Always. Because it's one point in time at the time they like the best, with the lowest blood sugar, usually when they wake up, and then that's it for the rest of the day. So in this case, to have this conversation about, here's a sensor, what do you think of this? Is this something you would like? But now we're doing this through a translator, and this lady doesn't have a cell phone. So now we're sitting here, we know we're not going to be able to easily get it covered on Medicare unless she's on insulin. But A1C of 10% likely needs insulin. So what, Davida, what you were saying earlier about putting a CGM on someone, they could see the value. That's great if they have a cell phone. So this one didn't have a cell phone. And I have had patients where there's a spouse who has a cell phone and one doesn't, and they're kind of together, and then it works.
Yeah.
So in this case, my recommendations and what we did moving forward was, AM finger sticks while we started a little bit of basal insulin. Now I can write the note today and get CGM from DME right away, knowing she needs a little insulin. It's just that I'm going to be cautious about it, and obviously educate for hypoglycemia and glucagon.
Well, you're setting her up for success. You're setting her up for success.
Exactly.
You're going through the steps ahead of time.
Yeah, and just to know, if she's using, I had to order a reader to go forward, and it comes in Spanish as well. Yeah. But the apps, if we're using the phone, all sensors have multiple language apps. So not that multiple, you can change the language to not just Spanish, multiple languages. So I think that that's also important, because that can be a barrier to its use. And, it's important to make sure that they understand what they're looking at, so we can't just send it to them in the mail with DME.
Did you
have
bring
someone
her back?
like this needs to come back, right?
Yeah.
And we can go over what they're looking at and make sure it's in the language that they're speaking. Yes. And make sure everybody understands what the alerts mean and what we're looking for. So she loved it.
Well, the other thing too is you can bill for her to come back and do the application and the training.
Mm-hmm. Sure, absolutely. And I think, she sees the value. It certainly makes the family feel better. We've talked about having apps when they're using a cell phone, that you can have family members be alerted to as well. Yes. And that's certainly important, especially if you did have an elderly patient or a young child or whomever that are away at school or live alone. So I think that there's a big ways to get over some of those barriers for technology.
You brought up the live alone. That's another thing I think we think of, but I like to do that top of line, because I can tell you multiple advanced age individuals with diabetes who live alone. And you know what? I've been putting that in the note. Have you ever done that, Davida? Have you noticed that might push it a little bit because you're in a social circumstance? Yeah,
there's a lot of things that I think aren't in the regs, but we put them in our note, and we use them for the prior auth, and we use them for when we have to challenge it, if we have to challenge if we get denied. So anything I can put in the note, I absolutely put in the note. And Jen, I think it's remarkable how you handled that. And I love that the family was able to come back and you were able to do it in the unit. But I also want to remind people that, sometimes we have to do it virtually, and we have to use, we have interpreters that will do video visits with us. So I just don't think that I can't think of too many things that would stop me from offering and getting someone up and running on continuous glucose monitoring. I mean, if the patient doesn't want it, they don't want it. But I think the patient who doesn't want it, either there's a financial barrier or they don't know what it is. We haven't done our job explaining what it is, because why would you not want to know how to manage your diabetes better and live, with all of this information? So I think great job.
You totally segued the comment we just had from a LinkedIn users. And they mentioned we're empowering both patients and providers with real-time data to drive informed decisions. It's incredible. They said it's incredible to see how many people have made lifestyle medications through that feedback, which you're absolutely right. And Jen, I love that case that you did. We encourage everybody to still keep talking about, who initiates, who educates, for CGM. Put that in the chat, what you guys have experiencing, whether you're doing it as the prescriber or you're sending it out. So Davida, talk to us a little bit about utilizing the entire healthcare team when it comes to CGM.
Well, and I would like to also say that I see within my team each of the pharmaceutical companies who within there have reps that do education, support the patient. There's new programs right now where they will do some follow-up as we start the patient. So in my team, it's we have diabetes educators in our system that will do face-to-face or they'll do virtual. We're very fortunate. They're not actually in our division. They're part of the whole system. We just write a referral. They pick it up within days. They'll help the patient figure out what it is, what it isn't, how to start it, how to put it on, everything they need to know. And then then we also have our medical assistants. Our medical assistants, if you come in with your whole thing, they will start the patient for us. They'll also make sure they're connected so we can see their data. They'll help the family members as well. And then, of course, the healthcare providers. And then we also like to make sure that our primary care providers, if we've started the patient on a sensor and we're looking online in one of the company's particular websites where we keep all the data, we want them to be providers as well. So we'll include anyone who wants to also look at the data so they don't have to worry about it. I can say, I just saw this patient. She's coming to see you in 8 weeks. The data will be uploaded for you to look to in your office. So that kind of partnership. And then there's 800 numbers educational from each of the companies that we all have to utilize because there's just so many of us. And we, but it's also the pharmacist is starting, not just the clinical pharmacists who have always been, part of the team. And I'm not saying that just because Jen's here, but it's true. But I'm also talking about retail pharmacists. I'm doing a presentation for retail pharmacist group at the end of May, and they want it just on technology because they want to be partners. Right. They want to be able to help our patients. So for me, I think all of those things all of those resources should be utilized, and we can meet the patient where their needs are.
Yeah, I'm going to interject for a second because we've got a new listener who says, what's CGM? Ooh, you asked the right question. CGM stands for continuous glucose monitoring for, these queens think, all persons with diabetes. You have diabetes, you qualify. You even have early diabetes. You want to know how food and lifestyle and medication and stress and day-to-day affects your glucose. So guess what? No more finger sticking. We don't like it. It hurts. And it's a point of time, a point of thing. But what we're talking about is the sugar queens is wearing a continuous glucose monitor, CGM, for 10 or 14 or 365 days, some of them, where you can get in real time your blood sugar, just like your speedometer, just like your gauges, just like your GPS. And, it's kind of interesting because we want to know, because you just threw it out there, what CGM. I want to know your response because we're still trying to educate and convince both patients and providers to use this. And I bet you'd be like, what? Why wouldn't they use this kind of stuff?
Well, the other thing is that in addition to all the education we're talking about, getting people up and running, I think all of us would agree that within each visit we do with a patient, phone call we do with a patient, in-basket message, that's another opportunity to continue to educate the person who has the diabetes and say, look, I get in-basket messages all the time. Can you look at my data? Can you look at my data? And I'm able to pull it up, go in and look. And then I'll take a picture of what I think is the most important for that particular person. I send it back with a message and say, I looked at your data. This is what I'm seeing. What do you think? This is what I would suggest for a change. Are you comfortable with that change? And then finally, I usually say, please let me know when that change is made. And since we've made a change, I'd like to look at your data again. Now, in some offices, you're able to bring that person back in and they can do another visit. We're not always able to do that. So I tend to do that through in-basket. But education is not just a one and done. And the American Diabetes Association standards care tell you that. It's ongoing. And, it's everyone who touches the patient should be helping with education.
Hey, Jen, we only have a few minutes left, but we have a listener who just put something out there that I want you to put his mind at ease. He says, do you think primary care is ready to prescribe CGM? And do they have the confidence to review the data due to added workload? Oh, just go tell him, Jen. Tell him.
So I am in primary care, and 80% of people with diabetes is managed by primary care. There's a shortage of Davida, Kruger queens out there. So we don't have enough. So, it's primary care does manage most of it. And I believe it's quicker. It's easier to assess.
You have
And
more time.
If you go back to some of the previous episodes and we go over the ambulatory glucose report, you can look at that so quickly once you know what you're looking at and really understand what is going on and make meaningful change versus somebody coming in with a bloody logbook or with random numbers.
You just guess.
Or scrolling through someone's glucometer. So once you understand that AGP, you can make changes quickly. So, you think about everybody's being followed up maybe every 3 months or so. It's so much better data than having just an A1C. So I do think it will save time in primary care for sure.
And you can bill for it too.
And the other thing I want to say though is, yes, I agree with everything Jen just said, but I also want to say that when you put a sensor on somebody, their behavioral change just from wearing that sensor gets them to take medication, eat better, do a lot of things, and the A1C comes down without our intervention by just giving a patient a CGM. I think every healthcare provider should understand what the data is and use it, but not everybody has to use every graph, but giving it to the patient, the behavioral change alone, you'll see an improvement.
Hey, we have such an engaged group today. We have another kind of question that I'm going to field for a second. Okay. So our listener said, speaking of cell phones, biggest challenge is remembering usernames and passwords. Guess what I do? I put them in the chart. I put the user, I put the different logins, the apps, every person I put in the notes. This is your username. This is your password. I have access to their data anyway. My MA knows they're connected. Hey, go back to some of our episodes. We talk about that. Yep. I even figure out their Apple ID. Yes, it's challenging. And so you have to be prepared for the engagement. If you're proactive rather than reactive, like if I'm going to have somebody come in for a CGM application, I give them a piece of paper. I need your Apple ID. Are you going to use a reader? Are you going to use a phone? I'd like your passwords. I'm going to store them here. I sometimes put them on the back of the reader. If you put a little label maker, we do it on the back of the reader. If you do that, we do the different ones for the phone. There's so many ways to do it. Do what works for you, because you're right. There are barriers. We want to identify those and overcome them, because don't get stuck. And so one of the things we did is workflow. We have a workflow video. Go back. There's some amazing stuff looking at workflow. Now, another listener talked too, which might be in the future, because Davida mentioned it too, about coverage and stuff, that they have higher glucoses that are outside the normal range, but their A1C doesn't qualify for CGM. So we need to stay tuned. I'm actually starting research next week on utilizing CGM in prediabetes. And so it's not there yet, because remember, us queens, we are ahead of schedule, right? We are ahead of schedule. Okay, ladies, we got about 2 minutes before we wrap it up. We want to make sure everybody's getting their CME for this activity, and that you scan that QR code. It was up a minute. It'll probably come up again. But any last parting thoughts that you have? We have one more queens next month with our buddy, our Prince of Glucose, right? Dr. Richard Bergenstahl is going to be with us. We're so excited about that. We haven't had a Prince come on, a sugar Prince, so it's going to be special. So any parting thoughts before we leave you all?
No, except for the one that we keep telling you, everybody deserves the right to wear a CGM.
Yeah, and I think we shouldn't let technology or the fear of apps or age be a barrier at all for the use of sensors for CGM. Everyone deserves it, like Davida says. It should be a right, not a privilege.
Not a privilege.
Yep.
Yes.
Thank
My
you
favorite Davida quote.
I loved the engagement today. We want you to catch the fever that we have for our persons with diabetes. It's been life-changing for us as clinicians and them as patients. Remember, mark your calendar for our live social event next month, as we have our special guest, the Prince of Sugar, Dr. Richard Bergenstahl. He's going to be with us to discuss the whole enchilada, connected systems, how all these diabetes technology work together. We're so excited to see you next month. Remember, we have all those archive sessions if you want to look at prior Sugar Queen episodes where we tackle so many different topics. Keep the conversation going, keep the education going. Thank you so much. And from us three queens, have a great day.
Thank you. And you can get CME from the previous sessions too.
Yep.
Awesome.
Yeah. Bye.